It's my pleasure to be chairing this episode of Methods Mondays. Unfortunately, Dr. Catherine Donnelly is unavailable. She was in transit coming from Heathrow. She had some mechanical problems with the plane, so I'm filling in. And Dr. Candidate Fikadu Yehualashet will be talking today on the adaptation of diabetes self-management coaching program. And just by way of introduction, I'll do a small land acknowledgement. We acknowledge that we're on the traditional lands of First Nations and Métis people and recognize their long-standing presence and contributions to this land. And having said that, I will pass it over to you, Fikadu.
Okay, thank you so much, Elliot, for your introduction. So for the next 1 hour, we'll talk about intervention adaptation. So introduce what intervention adaptation is and some important considerations, adaptation frameworks, and we'll see some practical examples of adaptation, particularly on diabetes self-management. Then we'll go through the adaptation of diabetes self-management coaching. That's my study. Okay, so let's go to the definition. Before we go to adaptation, let's talk about evidence-based intervention, because the evidence-based intervention is the one translated into different contexts. So it's a program, practice, process, policy, or a guideline that have proven efficacy or effectiveness through rigorous research in a particular population or in a particular setting. And evidence-based practice is also another relevant concept that might be translated into a different context, and it is integration of best available evidences, clinical expertise, patient preferences to guide practice and improve quality of care. So having said this, adaptation is a systematic modification or tailoring of an evidence-based intervention to fit a new context or to meet the needs of the target population. And adaptation can be planned or unplanned. And a planned adaptation is the one that intended to maintain a balance between fidelity and the context. Whereas unplanned adaptations can be changes made in reaction to some specific circumstances, or adaptations or modifications conducted while we are doing some adoption of an intervention, and there is a need for modifying some concept or some aspect of the intervention. Okay, so what are the reasons behind adaptation? There are various reasons. The most commonly mentioned includes when we need cultural appropriateness, just when we intended to implement an intervention to a specific culture, we need to approve or we need to examine the appropriateness of that intervention to a specific culture. The other might be when new target population or community setting is identified to be tested or to examine the intervention in a different context. And it might be also to condense or shorten an existing effective intervention. Like after every feasibility trial of or after every adaptation, there might be some considerations to modify an intervention, or so people may want to condense or may want to shorten their original intervention. And making a progress, a program widely available might be also another strategy to adapt. And ensuring sustainability of program effectiveness is another rationale for conducting adaptation, particularly if an intervention is just directly adopted from one context to another, it might not be effective. And if it gets effective or if it becomes effective, the effect might not be sustained. So having adaptation or having conducted adaptation prior to adopting an intervention will help to sustain the intervention. So evidence-based interventions might be efficient than developing new programs or new intervention. It might be in terms of cost, in terms of time, in terms of the the contribution of available experts. So it's very crucial to consider adaptation while we are planning or trying to test an intervention which is somewhere effective. Okay, I have an interesting model showing the taxonomy of adaptation or the types of adaptation. This model is developed by Chambers and Norton in their study called Adaptam, Advancing the Science of Intervention Adaptation. They propose 5 types of adaptation. The first is modifying the service setting. So in respect to the setting, they may suggest modifying who is going to deliver the intervention. For instance, if the original intervention was proposed by nurses and we would like to take this intervention into community setting, we may propose the intervention implementers to be community-based health workers or community health professionals. And the other might be target audience adaptations or changing the target population. For instance, in respect to age, an effective program conducted among elderly people might be translated into youngers or to children. And we may also translate or tailor a program which is effective among the some disease condition like hypertension into people with diabetes or heart failure or other chronic health conditions. So here, our target is just to change the population and trying to examine or evaluate the effect of the program on that specific population. Again, there's also another strategy of adaptation, like changing the delivery method or the mode of delivery. In this respect, researchers suggest the modification of the number of sessions. Particularly, this study is designed in behavioral health science. So we may need to modify the number of sessions, or we may need to modify the dose of the intervention, like the frequency of the intervention or the length of the intervention. Again, the other important consideration is cultural adaptation, particularly emphasizing on the culture and on the language of the intervention. When we wanted to implement an intervention which is somewhere effective in some cultural context, taking that into another context needs modification or change in language. Beside to language, there might be also a need for modification of other elements like some sensitive elements. For instance, in the case of diabetes self-management coaching, the program was originally tested in Indonesia, and the dietary culture is different. So the food recipes are different. So we have to change that. That's a part of culture. Yeah, the last component they mentioned is core component modification. This is the one which needs very cautious intervention, because modifying the core elements partly may affect the fidelity of the intervention. So changing the core intervention is also possible because, in a sense, adaptation is it can be deletion or addition of a certain core intervention component. So it is also mentioned as one component. Okay. A systematic review and evidence-based public health intervention conducted by ISCOFER in 2018, they tried to show us the different types of adaptation, and they just to illustrate the number of studies who conducted the specific types of adaptation. So they found that content, context, and the delivery modifications are the most frequently mentioned types of adaptation, and the content and the context is the second. So they just try to show which type of adaptation is most frequently mentioned. So around 6 studies mentioned almost all types of adaptation except the cultural aspect of the adaptation. Okay, let's come to the important considerations during intervention adaptation. So one of the most relevant thing to be considered during intervention adaptation is reviewing the strengths and the feature of the evidence. Yeah, if we are just taking an intervention which looks like evidence, which looks like a valid evidence, and take that intervention, we may fill up with poor outcomes. So we have to evaluate the intervention. We have to evaluate the strengths or the quality of that study before we are just taking into as a model intervention. So the second consideration is understanding the context and the stakeholders and the fidelity. This will be discussed in the coming slides. Yeah, context is the most important aspect because we mostly, as we see from the study conducted by Escoffery, context is mentioned in all types of studies. They reviewed around 42 studies, and 38 of the studies mentioned the context as a type of adaptation. So context is a very crucial element, and it is defined as a set of active and unique characteristics and circumstances that may interact with or modify, facilitate, or constrain intervention delivery and its effect. And the context is very broad concept. It might include geographical, organizational, or service-related, or practice settings, epidemiological, sociocultural, socioeconomic, ethical, legal, and political landscapes that might directly or indirectly affect the adaptation process, the implementation, and the evaluation of an intervention. The other important aspect to be considered is the stakeholder involvement. Knowing the stakeholders and engaging them in the process of adaptation will help us to understand the key values, the skills, knowledge, and experience of these relevant agencies. So stakeholders can be involved at a different stages of the adaptation process, and they can even also selected part of it, and stakeholders can involve in the advisory board of the definitive trials. So according to the ADAPT guideline, local community leaders can be considered as stakeholder, as a member of the stakeholder, target population representatives, intervention developers, topic experts, practitioners, and policymakers and researchers are mentioned as important stakeholders. Okay, fidelity is another important aspect we need to be considered while conducting adaptation. So it is retaining core intervention components that are responsible for the efficacy or effectiveness of the program. Always there is a tension between adaptation and fidelity. The more we conducted the adaptation, or the more we go deep into the adaptation, or the more we modify the intervention components, the more the fidelity will be compromised. So there has to be a balance between adaptation and fidelity. So this can be cleared through identifying and revising core intervention components prior to the adaptation process and consulting consulting developers of the program and experts about specific core intervention components. For instance, if we want to modify the theory, which is considered as a core intervention component, a core component of an intervention, we have to ask the original intervention developers why they prefer that theory, if it's not explicitly mentioned in the study. So the same wise, if we want to modify some pertinent elements, for instance, goal setting in our study is a crucial element. If we want to modify this, we have to ask the original intervention developers or experts to know more about why they intend to include it, because we think that this component is not relevant and would like to modify. So we should know the clear rationale behind involving or including that component. So fidelity can be assessed in terms of adherence to the program protocol, like assessing the dose of the intervention or the amount of the program delivered, and the quality of the program delivered and participants' reaction and acceptance can be assessed through feasibility and acceptability studies. Okay, so coming to the adaptation frameworks, as suggested by different experts, adapting intervention should be guided by frameworks and models that are developed through rigorous reviews and different approaches. So the most commonly mentioned adaptation frameworks include the ecological validity model, the dynamic adaptation process, the cultural adaptation framework, and the adapt guidance, which is the one we followed, and the one will be deeply discussed about this. Okay, so the adapt guidance is developed through the adapt study, and this study is funded by the United Kingdom Medical Research Council and the National Institute of Health Research. And it is called, this diagram, this beautiful diagram, is the part of the adapt study, and it's considered as the foundation of the adapt guidance. So Movician and the colleagues developed this diagram from reviewing 38 interventional adaptation guidance, and they propose 11 specific stages of adaptation, and these 11 stages are bounded with 4 phases. And the first phase is exploration phase that includes initial assessment or need assessment, then intervention selection or identification of the right intervention, the intervention exploration or knowing detail about the intervention, knowing detail about the context of the original intervention and the effect size or the magnitude of the effect and the outcomes assessed, and also the setting of the intervention. So this important information and exploration will help us to evaluate the fit of the original intervention with the new target context. So the second phase is a preparation phase. So under this, we'll consider identification of potential mismatches between the two contexts and intervention model development, proposing a draft intervention manual and intervention components. Then establishment of networks, capacity, and infrastructure. For instance, identifying the potential stakeholders that can engage in the program, and also the potential infrastructural resources, and also the financial resources are very crucial and that have to be prepared ahead of doing the adaptation. And then the third stage, they mentioned the implementation. So that's the action phase of the adaptation, undertaking modifications, pilot testing or pilot evaluation, and intervention revision and implementation are mentioned here. And the last stage is sustainability, and evaluation is another component here. The study should be evaluated before a large scale implementation, and maintenance and re-evaluation is also another component. So what we understand from this diagram is intervention adaptation is an iterative process. It's not just a linear process. We have to do it again and again, like until we reach into the most effective interventions. We may continue conducting the adaptation. As you know, context is not constant. There might be different factors affecting that. There might be a change in the need of the population. So this adaptation might be cyclic. Okay, coming to the ADAPT guideline, the ADAPT guideline is conducted through rigorous different stages of research. The first is the one I mentioned earlier, a systematic review of 38 existing guidance and a scoping review of 28 studies on current practice, particularly on a different health conditions, like studies conducted adaptation on diabetes, on hypertension, pain management, and other chronic health conditions were included here. And they also conducted a qualitative interview with researchers, funders, policy or practice stakeholders, and they undergo through 3-round Delphi to reach into consensus. And finally, they developed a 4-stage consensus-informed guidance that is the ADAPT guidance. Okay, so the ADAPT guidance has 4 stages. The first one is assess rationally for intervention and consider intervention context fit. The second is plan for and undertake adaptation. Then plan for and undertake piloting and evaluation. And the last one is implementation and maintaining the intervention or the adaptation at large scale. Okay, coming to some practical examples, I have a couple of studies conducted on intervention adaptation. The first study conducted by Diego Osna and his colleagues, methods for cultural adaptation of Davis lifestyle intervention for Latinos. So they followed the 4 steps of adaptation proposed by Barrera and Castro. So the first step is information gathering, preliminary adaptation design, and preliminary adaptation tests, and adaptation refinement. So they adapted the Mediterranean lifestyle program to Viva Bain for Latino women. So you can imagine how the cultural context is different between Mediterranean people living in Mediterranean area and people living in South America. So they modified diets, particularly they changed the food recipes, and they also make the flexibility of the exercise choice, and they make restrictive into walking and instructional exercise. And they also added family involvement in the program, which was not previously mentioned, and the cooking demonstrations included. And they also included, based on the suggestion of the study participants, they included physician involvement in the health education program. Okay, the other pertinent study I brought as a practical example is cultural adaptation of a mobile health intervention for diabetes self-management. It is the follow ecological validity model. So similarly, it have 4 steps: the need assessment, verification of adaptation blueprint, pre-testing of adaptation intervention, pilot testing to assess intervention feasibility and acceptability. So they adapted a mobile health diabetes self-management coaching and support to individuals with type 2 diabetes, particularly Vietnamese living in the United States of America. So they modified the language specific to the Vietnamese. They modified the metaphor, the content, the context, and the implementers. So we can see some commonalities like the number of stages and each element mentioned in the specific specific models they followed. Okay, this is the adaptation of diabetes self-management coaching, our study. We followed the ADAPT guidance, and we initially assessed the rationale and the context fit. So, coming to the rationale, diabetes in Ethiopia is a high prevalent problem, but it's a neglected condition. Yeah, and some systematic review and meta-analysis show 6.5% prevalence, but the IDF report is about 3.2%. So there are variations, and the prevalence is very higher in some specific areas, like in Dredoa region, which is about 14.9%, even which is very higher than the most of the high burden countries in the Western. And Ethiopia is one of the 4 sub-Saharan African countries with high burden of diabetes or high adult diabetes population, and is also among the 4 countries in Africa and sub-Saharan Africa with high days of diabetes-related mortality. So because of this prevalence and the burden of the disease, we intended to adapt an intervention, and there is no structured educational program, diabetic education program in the country. There is no also effective diabetes self-management program. So we intended to adapt this intervention. In addition, if we just plan to develop an intervention, it might be very expensive, and even we may not get the right people to do that. So the limited finance and human resource available in the setting enforce us to adapt an intervention rather than considering development of a new intervention. Identifying an evidence-based intervention was the second step. We reviewed 5 systematic review and meta-analysis. One of the most recommended steps in the ADAPT guidelines is conduct systematic review if it's not available. But fortunately, there have been more than 5 systematic reviews and meta-analysis studies on diabetes self-management and coaching. So from this and from the other reviews, we identified 5 diabetes health coaching studies. And from this, based on some specific criteria like studies conducted in the primary care, studies conducted in low income setting, and a study conducted in and demonstrate effectiveness on some clinical parameters like hemoglobin A1C and some behavioral outcomes like self-management behavior and self-efficacy. So we identified one study that is self-management based coaching program, which is effective in the primary care of Indonesia. And we reviewed the context match of the 2 settings. So we learned that the health system in both Ethiopia and Indonesia is relatively similar. Both follow 3-tier health system, and the primary care is the heart of the health system in both countries. And both countries are affected by a huge burden of disease by communicable disease, non-communicable disease, and maternal and child health problems. And the socioeconomic landscape also looks like similar. That's why we select this study and conduct the adaptation. Then the other relevant aspect we conducted in the first step is establishment of adaptation team. We established a multidisciplinary team of 13 professionals from nurse practitioners and researchers, nurses working in the hospital, in the primary care, occupational therapists, physiotherapist, epidemiologists, and nutritionists. And we also involved target population from individuals with type 2 diabetes to incorporate their perspective. So the second step of this study is conducting the adaptation. So we established the team and make introduction of the adaptation process, the purpose of the study, and we tried to build rapport among the team members and make the team members or the adaptation team members in the same table. Decide on the grounded rules and consensus mechanisms. And we also decided the extent of modification. What area should be modified? What should be reserved? And we conducted 3-round expert panel discussions. In the first expert panel discussion, we review intervention components, delivery method, and the context, and decide on the changes. And the second panel discussion, we reviewed the draft adapted intervention and also suggested some comments for further development. In the third panel discussion, we reviewed and approved the intervention manual and work on language translation. So these were the steps we followed. And this is a picture taken during intervention adaptation. Okay, coming to the modifications, we conduct content modification. For instance, basics of diabetes has been added. In the original intervention, there was no basics of diabetes, but from our review, we found that there is a lack of knowledge related to diabetes and its management, so we added basics of diabetes. And we also modified the naming of intervention components like role play and brainstorming were mentioned as intervention component rather they are delivery methods. And where assessment of biomarker is remote because we didn't take biomarker assessment, rather we take biomarkers from the patient medical record. Physical activity and the medication adherence separated as a single intervention component, which were originally merged together. Meal preparation was changed to plate method, picture review, and experience sharing because the context is not appropriate and the culture is not also appropriate to have a meal preparation because the people follow a diversified types of meal, and it would be also more prescriptive if we just specifically prepare some sorts of meal for that context. So we prefer other methods of dietary education. The diabetes self-management experience was incorporated into each self-care behavior. Initially, there were certain components, a specific component of experience sharing on self-management, but what we do is we incorporate self-management in each component, like in diet management, people will share their experience. In exercise, they will share their experience, so we incorporate under each self-care behavior. Goal setting was merged with other components, and we bring this as a separate intervention component because we believe that this is a pillar of health coaching. Discussion with family discussion with family was another component, but we changed this into family orientation following home-based coaching. And a monofilament test to check neuropathy has been removed and replaced by food care and food inspection as a separate component. Contextual modifications include facility-based coaching changed to community or home-based, and the PI facilitated the coaching session, and nurses and nutritionists performed contribute in the adaptation and manual development. And then in the original intervention, it looks like multidisciplinary. They involved nurses and nutritionists in the intervention administration, but we just modified this into another platform. We combined group and individual coaching to be holistic, home-based coaching linked with family orientation, and the role play for blood glucose monitoring changed to demonstration. Telephone checkups changed to 4 home-based coaching sessions, brainstorming replaced by an interactive discussion. Lecture method was changed into interactive discussion and experience sharing. And the number of sessions changed from 8 to 10, and number of visitors to health facility changed from 4 to 6. And lastly, we changed the culture and the language. The intervention manual was translated to the local language, Amharic, and cultural sensitivity on dietary recipes and exercise elements were modified depending on the culture. So we involved individuals from the linguistic department, particularly English language studies, and one sociologist involved in the cultural translation, particularly. So this picture is taken during the cultural modification, cultural translation of the manual. Okay, so the third step of this diabetes self-managed coaching is pilot testing. We conducted pilot testing. A parallel group pilot randomized control trial was conducted among 40 individuals with type 2 diabetes to assess the feasibility of the program in a primary care and acceptability of the program by individuals with type 2 diabetes, and fidelity of the coaching session and overall program, and preliminary effectiveness of the coaching program on clinical and behavioral outcomes. And we follow the concert participant recruitment and flow diagram. So we screened around 252 people, and we end up with 57 participants are eligible. And we finally reach into 40 participants were recruited and randomized after taking the baseline data. So 20 people, we just followed the block randomization with a block size of 4. And we also applied an opaque sealed envelope to allocate participants. And 20 participants are allocated into the treatment group for a 12 weeks diabetes self-management. In addition to the usual care, and 20 people into the usual care. We assessed that after 12 weeks, and the post-intervention assessment, and we followed the participants for another 12 weeks, and we assessed the post-follow-up assessment. And in the meantime, after the post-intervention assessment, we also conducted a qualitative interview just to assess the acceptability and the feasibility aspects, because this is a mixed study. Okay, this is the study setting. I just take this picture from one study conducted in 2022 by Tamru. So this is one of the health center we facilitated group coaching. It is Gondar Town Health Center and is commonly known as Poly Health Center. I have few images, like these are the group coaching facilitated in the health center. And this one is the individual home-based coaching. This is the study data allocation into control and treatment. Yeah, so the fourth step of the ADAPT guidance is the implementation and the maintenance of the adaptation into a large scale. And we are hoping to do this in the definitive trial. Yeah, so this is all about, and some of the challenges of the intervention adaptation process were accessing the selected intervention manual was very challenging. It takes around 4 months to get the intervention. Once we identify the intervention, just to get the intervention was, it was time taking, and it was the hardest part. And having right people at the table was also another problem. We were intending to include people who have health coaching experience, but unfortunately there are no people working on that area. And we just include other people like who have coaching experience, for instance, occupational therapists who have coaching experience, they took coaching course. And I also have a counseling experience, a rich counseling experience, and I took also coaching course in Queen's University. And the lack of resource, financial resource is also another challenge, and lack of willingness to participate. Some people reject to, particularly people working in the leadership area, are not willing to participate in the process. And socio-political instability was also another challenge. So in conclusion, intervention adaptation play a crucial role in improving the health of individuals living in a resource-limited setting, and it saves resource and foster knowledge translation to a different context. Intervention adaptation should be guided by models and frameworks and demonstrate transferability. The Davis self-management coaching program was effectively adapted and piloted in the primary care context. These are sample references. So I'd like to acknowledge my supervisor, Dr. Catherine Donnelly, my supervisor committee members, Dr. Dorothy and Dr. Saganat, research assistants, the adaptation team members, the data collectors, nurses working the clinic, and in the diabetic clinic, a study participant, intervention developer, and Queen's University, University of Gondar, Mastercard Foundation, and my friends and family. Thank you so much. If you have any question, I'm happy to discuss and learn from each of you. That's all.
That's great, Fikadu. Really an impressive deep dive into the adaptation and fidelity considerations for program provision for your RCT. Really, really interesting. Maybe I'll just open it up. I have a number of questions I'd like to ask you, Fikadu, but I'll open it up to the participants there, and if anybody wants to put Fikadu on the spot on this Methods Monday, that'd be great. Yeah, go ahead, Jordan.
A great presentation. Really nice to see your work progressing along.
We're just having a hard time hearing you, Jordan.
That's because I have my microphone on my head.
There we go.
Elliot, thank you. Thanks, Fikadu. Great presentation, and really nice to see how your work's evolving. That's really exciting. You mentioned one of the learnings or discussion points that you mentioned at the end was having the right people around the table, and you mentioned that from the context of people with health coaching experience. But I wondered if you could speak to like the involvement of health system decision makers, policy makers, people that, you know, if you went down the road of a full scale trial and it were effective, you know, and I wonder if you've had the chance to involve any of those folks along the way, and in what ways, beyond, you know, the people that could deliver the coaching.
I just tried to hear some components of the question. Anyways, we just tried to involve around 30 people who have different experience. But yeah, the problem was having people the actual experience in the local context, the actual experience of diabetes, not diabetes, of course, health coaching experience. That was the hardest part, but we just try to mitigate that through once we develop, we try to engage other people. Like one of my supervisory committee, she's expert in coaching. So she have a chance to review all the guideline, all the intervention adaptation manual. So yeah, I try to benefit the intervention adaptation from the other people who are living in the center, like who have diabetes self-management experience. They have the chance to review and give me pertinent comments. Yeah. Thank you for asking, Dr. Donna.
Yeah, sorry if you could do it. I think I may have been cut off in my question a little bit. My question was more about policymakers or health system decision makers and their engagement, whether you've had any opportunity to do that or not. I put my question in the chat in case it is unclear again.
Yeah, we try to involve them, but by chance we only have one primary health care leader who was working in the health center. So yeah, we have a chance to involve the one person from that, but the rest it was not possible to get their saying in the process. Yeah.
Thanks for the question there, Jordan. Fikadu, one of my things that struck me was just how you arrived at your sample size in terms of both of your arms, 20 in each in your experimental control arms. Can you talk a little bit about how you arrived at that, and then power considerations? I know also considerations for practicality and a PhD type resources. But yeah, if you could talk a little bit about that. And then the second piece was, did you have any accrual challenges once you had people selected to each of the arms? People dropping out, or can you talk a little bit about that?
Yeah, thank you so much, Juliet, for your questions. Yeah, in regard to sample size, there are different recommendations. One of the recommendations is just to follow the rule of thumb. And yeah, we followed Hergo's recommendation of study participant allocation for pilot and feasibility studies will be 10 to 14 in each arm. So yeah, we didn't go through actual sample size calculation because yeah, there are different suggestions. So we don't need to have, like some says, we don't need to have sample size calculation for feasibility trials, and some says there might be some sample size. So we didn't do that, but we follow recommendations from experts, and we allocate study participants in that way. And there have been some dropouts, like there were 2 dropouts in both sides, a total of 4 dropouts. Yeah, surprisingly, the study participants were interested to stay in the program because there was no other alternative. I have been working there. I have been there for even during the study period. There have been a lot of people in the waiting room, and there is no chance of health education. So the only chance they may have education about is during their clinical visit. That 15 to 20 minute clinical visit doesn't give them adequate knowledge. Rather, the physicians will say, do exercise, but the people do not know what kind of exercise they have to do. They don't know how to do the exercise. And they recommend them not to eat sugar. You have to cut, they say that you have to cut sugar, but this is not the right way to teach people. Rather, we have to teach them balance their diet, like including vegetables and fruits in their diet and proteins in their diet, and minimizing the amount of sugar or carb diets consumed daily. So as there is no structured education system, so that's why people are more prone to stay in the program, and we end up with 36 people at the end of the study.
Great. Thanks, Fikadu.
You're welcome.
This is Adanam. I see you got your hand up.
Yeah. Can I ask
Yeah, you got the floor there, Adam. Go ahead.
Okay, thanks. Thank you so much, Fikadu. It's a great and informative presentation. I have two questions. The first one is, how do you choose the intervention? Because there are a lot of interventions for almost any problem. And how do you decide which intervention to adapt and which not? And the other thing is, when you're doing the discussions, there will be the more stakeholders are involved, then the more variety of ideas will be raised. How do you decide like the consensus? Consensus. Yeah. These are the two questions I have. Thank you.
Oh, thank you so much, Adanam, for your questions. Yeah, the first is choosing intervention. Yeah, as just a buffet and choosing the right food from the buffet. So what we do is just initially it is recommended to conduct systematic review according to the ADAPT guidance, but there have been plenty of systematic reviews. We found more than 7 systematic reviews, but 5 systematic reviews were specific to diabetes self-management coaching. So we decided there is no need to conduct the review because there are up-to-date reviews. So what we do is reviewing that reviews. We reviewed that studies, and we just try to select pertinent study which is more closer to the setting. For instance, we consider the setting should be primary care, and the study should be effective in changing the clinical outcomes like hemoglobin A1C changes. And we also assess the intervention is conducted in low-income setting because we are just borrowing this intervention to the low-income context. So based on this consideration, we identified that intervention. Thank you. And yeah, the other question is about consensus. Yeah, this is one of the important things we just considered. We followed the nominal group techniques to reach into consensus. So what we do is we initially orient how we just go through the process. And every part, for instance, when we are dealing about the first intervention component, every group member have a chance to identify whether that intervention component should be retained or should be removed. And everybody should be also bring some justification. So through that, we just take a pool, like among the 8 people, if 5 people says we have to remove this intervention component, we'll take justification from each. And if the justification is convincing, we'll decide on that. So that's the way the nominal group technique is applied. That's the way we applied that. Thank you.
Okay, if you could, I have another question here for you. So is the area you've selected out is a huge area of program provision in Ontario, obviously. And I'm just wondering, you've spent a lot of time in this area, and this sort of builds on Jordan's comment earlier about the policy folks. Do you have any learnings in an Ontario context for policy folks who are responsible for providing these programs, or secondly, people wanting to do like study in this area in terms of looking maybe RCTs or maybe not even an RCT, but looking at other studies. Any learnings from your work for the Ontario context?
Yeah, thank you, Elliot, for your question. Yeah, as a scientific evidence, the evidence generated from this study can be transferable and applicable across the world. Any people can use that. And specific to the Ontario context, health coaching in the primary care context is not well utilized and applied. There are very few studies conducted in the primary care context. And in some contexts like Australia and United States, they just try to integrate health coaching in their primary care context, in their health system. And the patients are just benefited from that program. So the primary care context in Ontario through rigorous researches maybe coming in the next time, they may have the chance to incorporate health coaching into the health system, and people with diabetes may be benefited. It might not be like in the same format like the group coaching and individual coaching, but the approach should be changed. Like we may design some application-based coaching or AI-based coaching. Yeah, so yeah, we can transfer the knowledge to this setting too. Yeah. Did I answer your question, Elliot? Okay.
You're on mute.
Yeah, he showed me the sign. It's okay.
Elliot, you're muted, sir.
It's 12:53 now. I'll give one last opportunity for anybody on the call to ask any questions if Fikadu. That was really great today, Fikadu. Thank you very much for taking the time out of your day and presenting on Methods Mondays. Maybe I'll give people 7 minutes back to their day and go out there and enjoy that warm weather we have after the ice storm.
Yeah, thanks so much for having me. Have a great day. Bye.